in today's episode of the Global PAD Impact Awards, we are announcing the Gatekeeper of the Year award. In the ongoing battle against peripheral artery disease, or PAD, primary care physicians or general practitioners stand as the first line of defense, playing a pivotal role in early detection, patient education, and coordinated care. Today, we are thrilled to announce and interview the winner of the Global PAD Association's prestigious PAD Gatekeeper of the Year award because of that important role that these primary care physicians and general practitioners play in that early detection of PAD. This distinguished accolade recognizes an exceptional primary care physician who has demonstrated outstanding commitment to combating PAD. Our winner has not only championed PAD awareness, but has also mastered the art of early detection, education, and facilitation of early vascular care. As we unveil this year's recipient, we celebrate a true healthcare hero whose dedication is literally saving lives and limbs. Their work exemplifies the crucial impact that informed, proactive primary care individuals can have on managing this critical vascular condition, a condition that is more prevalent and deadlier than most cancers combined. So join us as we spotlight this remarkable individual who serves as a beacon of excellence in the fight against PAD. Their story is not just one of personal achievement, but truly an inspiring example of how primary care physicians and general practitioners can actually lead the charge in transforming vascular health outcomes for communities across the globe. So without further ado, the 2024 PAD Gatekeeper of the Year is Dr. John Robert Coates from Ontario, Canada. Congratulations, Dr. John Robert Coates. We appreciate all you do to help save life and limb.
Thank you for this honor. It's a pleasant surprise to get your email announcing this.
Aw, well,
Thanks.
you just mean the world to me and so many patients that you help daily and help facilitate getting to early vascular care. It's something we wish we had across the globe, and I hope that this award serves as an educational opportunity for other primary care physicians and general practitioners to hopefully replicate what you are doing to improve care for PAD patients in your area. But I wanted you to share with us your personal journey that led to your passion for raising awareness about PAD.
So my personal journey with regards to PAD, the most shocking part was when my sister Melissa Coates, who was a famous bodybuilder and wrestler, suffered an acute ischemic limb. So suddenly she developed leg pain and presented to the emergency department shortly after this started. Actually, she presented to an urgent care clinic and did not have her pulses checked, her neurovascular status. They didn't check sensation, temperature, cap refill. All this was not investigated, and they ordered a venous Doppler, which came back normal, and basically told her they thought she had a muscle strain or Achilles tendonitis. So shortly after that, uh, she presented to an emergency department in Las Vegas, where she lived, and was told she had an acute ischemic limb, and they tried some procedures to try to save her leg, but ultimately it had to be amputated above the knee. And this was a huge shock to her and to the family because she was only 52 and was pretty much the healthiest person in the family up until this point.
And so, with that, it's so interesting because you said they did the venous Doppler, and I hear this all the time when a patient goes to the emergency room. They're always checking for a DVT, but a lot of our patients, right, and such as your sister, get the blood clots in the arteries. And shouldn't they be checking the arteries as well? So when they do the Doppler, why not do both? Why not do both veins
Yeah,
and arteries to make sure that there isn't clot in the artery?
correct. So we'll kind of never know because she didn't have the arterial Doppler early on, but we suspect that perhaps this could have been caught sooner. And
So was there a
yeah.
specific moment as part of this experience that made you realize the importance of not just sitting back and letting this happen to other people and actually becoming proactive, not just in your own practice, but in your community to raise awareness for PAD?
So in my community, the impetus for a lower limb preservation strategy was, I guess, the government realized the immense costs to the healthcare system, both financially with direct costs for amputations and just the rehab after this happens. Not to mention like the social effects and psychological effects on people. They decided that this was going to be a goal of theirs to decrease the limb amputations in Ontario. And I was asked to be involved because of my personal and professional experience with limb loss and with PAD. So I got invited in after the Ontario government started this project. And I could tell you a little bit more about
Yeah, I would love that.
how that works.
Please. Yeah.
So, I mean, here's some of the stats they have in Ontario. Apparently, it costs $70,000 per major amputation in Ontario, and that's not to count the rehab and getting a prosthetic limb. 1,200 major amputations per year in our province, which has about 15 million people, and 20,000 minor and major combined. Anyway, the total cost is $140 million per year. And
Wow.
5% of these people die with a foot ulcer, die within 5 years. 50% have passed. And if you have a major amputation, 80% of people with an above ankle amputation have passed within 5 years. So huge mortality rate, huge cost. And yeah, so they decided to develop a strategy which involved 10 demonstration projects across our province. The province is divided into districts called Ontario Health Teams. I think there's at least 20 to 30 of them, and 10 of us were chosen. One of them was Windsor, Essex, where I live. And so each program came up, we're given seed money to come up with a program to screen and assess and help treat diabetic foot ulcers and prevent amputations.
That's incredible. When did you start this? Or when
So
did you get involved with
the
it?
I was invited in May of 2023, and the first patients came through in October 2023. So it's very new. Um, and so each district that had a demonstration project kind of came up with their own program. Each one's a little bit different. Some of them are based on how large the district is and how many patients are in rural areas. So those groups had a lot more I guess, technology. There's special glasses they can wear. The EMS and home care, wound care nurses and that can go out into smaller communities and send the images back to a vascular surgeon in the larger cities.
Glasses that they can wear for this?
Yeah, special glasses that have a camera in them, and I guess they can look directly at the wound you're examining.
You're kidding. I have not seen those here in the US.
Oh, wow.
That's pretty
Yes.
remarkable. Wow.
Mhm. So
And
my
this is
district is,
mainly,
sorry, yeah, this is in sort of the larger rural areas like northwestern
okay.
Ontario. It's like the size of France, apparently, and has only 200,000 people scattered throughout this vast area. And my county is quite small, takes, you know, 40 minutes to cross it. It has about 350,000 people. So not terribly rural. Most people can get to a hospital or vascular surgeon.
And we have our producer Josh that is asking about the technology. I don't know how much you know about the technology of these cameras. We're going back to those cameras because we're fascinated by those glasses.
Mhm.
Because I think they're such a brilliant idea. I had a pair of Google glasses like way back when they first came out, and then those just,
Mhm.
fell by the wayside. But that's pretty cool. Is it single cam or dual or 3D? Anything extra special about them?
I don't know exactly
Okay.
what the
No,
exact
that's, I
technology
just,
is. One of them's called Teleview, I believe.
okay.
I'll look up TeleVU.
Okay. Interesting.
And
Well, I just think that's really cool. So, these demonstrations they include testing and they're more targeting the diabetics. So they're looking for people that have these diabetic ulcers or have the potential where one might be brewing.
correct. So our program that we've designed will see people with an active foot wound, peripheral or without a wound, but who have peripheral arterial disease or suspected peripheral arterial disease, and definitely diabetics. Um,
Interesting.
so our program, we have a nurse practitioner who runs the clinic, and she's quite skilled, has some wound care training, and she kind of is the MC, coordinates everybody. Patients are referred by doctors in the community if they meet those criteria of PAD, DM2, and/or a wound. And she assesses them using a tool called the INLOS foot screen. Not
Okay.
sure if you're familiar with that.
Mhm.
And it kind of goes through like an inspection of their feet, looking at their skin, checking sensation, including the monofilament testing, the little plastic fishing lure that you poke on the feet, see if they can feel that, checking their vascular status, such as pulses. And if it's difficult to feel them, she has a handheld Doppler that she uses. And yeah, some general questions about claudication, intermittent claudication questions. She also inspects the feet for deformities. And this program has funding to help people who are not as well off. It's supposed to help improve equity by there's free transportation to the clinic. They actually have a satellite clinic at the homeless and help hub, housing and homeless help hub. It's called the H4. So they'll go down to the shelter and do a satellite clinic there to assess patients. As well, the program for people who are disadvantaged has access to free foot orthotics and orthopedic shoes, diabetic socks, and compression stockings. So that's a great advantage of the program.
Wow, that's fantastic. So is this something that is available every day of the year?
Monday to Friday.
Weekdays, Monday through Friday. Wow. And
Yeah.
do people schedule appointments or is this just kind of a walk-in?
It's by referral. So we get referrals from the emergency departments. The vascular surgeons and some of the endocrinologists have been referring, and mostly referrals from primary care. The
So,
referrals right now are by fax, but we're hoping to get an online referral system set up.
but the thing is that the general practitioners, the primary care physicians need to be educated about PAD, and
Mm.
that was part of the issue. It is is there extra education that is provided to the primary care physicians now with PAD now that the program is available for them to refer to?
Yeah,
Is
so
there additional, are they more in tune with PAD because of that?
I believe so. And we are doing an educational campaign. So I've done one webinar so far that we sent an invitation out to all the PCPs in the community. About 70 people signed up to watch that. So I gave a general overview of what I thought a PCP, primary care providers, should be thinking about when they think of foot care and saving limbs. And then we gave an overview of the program and the referral form, the INLOS screening tool. We're going to do some more educational webinars, and that's just in our area as well. Across the province, other demonstration sites have done more elaborate educational sessions, but they're all accessible to anybody in the province.
Is the clinic are the demonstration sites pretty packed? Or, we still have quite a bit of educating to do to start filling the time slots for these clinics.
Yeah, they are not packed yet. So they
Okay, that's
certainly
what I
could
was
be.
wondering. Okay.
So we got to do more
So still lots
educating.
more
And
education. So
yeah,
still that issue
so
that we have, we got to get those primary care physicians in the know with
tomorrow there's
PAD.
Essex County Medical Society Education Day They have this conference every year. So the Ontario Health team for Windsor Essex, they've got a booth set up there with some information about our program. So hopefully we'll reach a lot more nurse practitioners and family
Yeah.
doctors tomorrow. Yeah.
In your experience, how prevalent is PAD knowledge among private primary care, and what you learned, in your textbook through your time in medical school?
So in medical school, I think this is one of the least taught subjects. You hear so much about strokes and heart attacks and PAD, just wasn't really talked about much. I think I learned more about diabetic foot ulcers, and that almost, it's just seemed there back in the early 90s when I went to med school. I guess there were a lot less options. It just seemed like part of the disease. You're going to get diabetes, good chance you'll lose a limb. Um, but
Right, but they don't
nowadays,
really
they're
explain why.
saying
They don't explain.
85% of these, yeah, 85% of these amputations, they're saying can be prevented with proper
Yep.
foot care and education and early screening and interventions. So I think things have come a long way in the last 30 years. I'm
Because so many
embarrassed
of
to
those
say
diabetic
I'm like
ulcers,
that old.
so many of these diabetic ulcers could be, prevented if they just check the arteries and make
Hmm.
sure that the person's, blood vessels are open. But even here in the United States, and we get so many patients that come our way on deck for amputation that have never had a vascular evaluation. The
Hmm.
primary care physician sends them straight to an orthopedic surgeon or a general surgeon, and even to sometimes a vascular surgeon that will just go straight to amputation as well. And that's very frustrating.
There is.
What are the
So
main
yeah,
challenges,
about
do you think?
20%. Yeah, 20% of the diabetic patients have peripheral arterial disease. I think that's one of the stats I've read. So yeah, definitely we should be screening for that. I'd say people over 50 with risk factors should be screened, which the top two
Yep.
risk factors are diabetes and smoking. And of course, dyslipidemia, so high cholesterol. If they've got vascular disease in other beds, like the carotid arteries, stroke, heart, coronary artery disease, we might consider screening those folks, which could include an ABI, ankle brachial index, maybe duplex arterial Dopplers, and where they've got it, toe brachial index.
What are the main challenges primary care physicians face in identifying and managing PAD, do you think?
Mhm. Probably time, just the pressures during the day, seeing so many different cases, um, and then remembering to check the feet, get people's shoes and socks off. And we really have not been using a risk stratification tool. So the INLOS actually stratifies people based on whether they're low risk, very low risk, moderate, high, and extremely high or urgent. And
Yep.
it gives you information what kind of foot care should be provided, interventions that would help prevent amputations, and how often they should be followed up. So you might see somebody who's a really severe diabetic and then not see them again for a year. And that was a huge problem during the pandemic that people were just lost because they weren't coming into the doctor's office or the hospitals because they were afraid they would get sick.
Yep.
And often people were doing telemedicine, right? Just doing consult over the phone, which was totally inadequate for a condition like this.
Yeah, how do we
It,
prepare for the next? I heard something about the bird flu, that
mm,
they're expecting to be the next pandemic. How do we prepare for the next pandemic to prevent these patients in particular from falling through the cracks?
mhm. I guess the TeleView glasses will help, but that seemed to be after they got the wound. So yeah, I don't know.
Yeah.
Send everybody a handheld Doppler in your practice, but I think they're pretty expensive.
Listen, maybe take
They
getting
put this on
getting
your foot.
a yeah, like even a pulse oximeter, one of those
Mhm.
ones you put on your finger for your toe. That might be
Yeah,
really
I've heard that
cool.
that's a poor man's version of a handheld Doppler would be to
Yes.
put that on your great toe and see. But yeah, it should work.
So how do you think that medical curricula could actually be improved? Is that something that is that something that your team is working on to prepare future primary care physicians for diagnosing and managing PAD?
So my team is not directly involved with medical schools and their curriculum. It's a good idea. I should contact our local. We have a satellite campus of University of Western Ontario's med school here in
Hmm.
Windsor and see what they are providing currently. Um, what was the other part of the question? Just
No, I was just
bothering you
curious,
with
just if,
educating new doctors. I mean, I certainly think a lot more of these stats could be provided with the shocking fatality rate, that exceeds, I guess it's colon, prostate, and breast cancer combined. The 5-year
yeah.
mortality rate is worse for a diabetic with a foot ulcer or a PAD patient with a foot ulcer. Um, this needs to be told to all the primary care doctors and the med students and residents so they take this seriously and, you know, take more time with their patient, get their patient's shoes and socks off. If anybody comes in complaining of lower limb pain.
Yep. And I wanted to open up. We have quite a few people in our live studio audience that I'm sure have questions. I see Douglas already has his hand raised. Douglas, go ahead and unmute and ask Dr. John Robert Coates, our Gatekeeper of the Year award winner, your question.
It's great to see you again, and congratulations. That's really awesome what you do. We really appreciate it. And
Thanks, Doug.
I think a part of that is nailing is when you're in school, you learn about all the stuff about heart attacks and all of that we all, is so aware of. But why not put that into school so that the doctor has that on their mind, the primary physician, before they leave and get out into the community and not have to worry about getting that in the community a year later when they see somebody with ulcers or with wound care or have to do that. And I think that's really a big deal now is to try and get that into the medical school so you primary physicians become aware of that.
Yeah, for sure. I think it's going to happen. I'll try to find out to what extent it is at our local campus.
And Marcia?
I've seen the glasses, and that is that FBI kind of stuff and the Secret Service kind of stuff. But the glasses really do work, and it is surprising that you don't see that more in the health field community with nurse practitioners reacting with doctors.
Mhm.
Yeah. Thank you, Douglas. Marcia, go ahead and ask your question.
Thank you, Kim. Yes, doctor, your story is so interesting, to know that you've been affected personally, which I'm very sorry, but it kind of goes to show that no matter who you are, what economic maybe level you are, your brother's a doctor, that it really can affect anybody. And it's so sad. My question for you is, in your arena of other physicians that maybe you don't work with one-on-one, do you find that most doctors don't even know, primary doctors don't even know what PAD is?
I think most of them do know what it is, but whether they know the right questions to ask when they're taking a history and if they're taking the time to check pulses and, temperature and sensation in the feet. Those are the major barriers. And
So
part of
the
that may be
patients are
they're just not
following.
aware of, they may not be aware of, how fatal this can be and the
Right.
huge cost to the system and families to go through this.
And playing on what Marcia was saying is I think for so long there weren't treatment options. So what could you really do if you diagnose someone with PAD? You would just pretty much say, well, that's just due to your diabetes. You have artery blockages just due to your diabetes. It's just due to old age. And there's nothing that can really be done about it. It's a progressive disease and it is what it is. And if it gets bad enough, then we could do a major bypass or we can amputate. I mean, treatments have come so far, and I think it's been really hard to get that information also trickled down to the primary care level, especially for some of the folks that have been around for a while as primary care physicians. They may not be aware of some of the newer treatments that are out there, and that, yes, if you get to us sooner, we can just open up those arteries with a wire and a balloon. Do you think that that plays some sort of role at the primary care level as to why maybe they're not as focused in many areas on PAD and truly diagnosing them and getting them to the vascular care they need?
I think most family doctors are aware of these newer procedures.
Huh.
I'm not sure what would prevent them from. I mean, I think anybody with a patient with a foot wound is going to nowadays consider, getting their vascular system assessed with an ABI and Dopplers and getting them to a vascular surgeon, plus a referral to the wound care program. So our wound care is generally through our home care system, Community Care Access Center, it used to be called. It keeps changing its name. And so our nurse practitioner will liaise with the wound care nurses. She does some wound care downstairs in my clinic. And there's a vascular surgeon actually in our building. She consults with him across the hall, which is kind of handy.
And we have Kim that has a comment, I believe. Kim, go ahead and unmute and share a little bit of your experience.
Yeah, I was just going to say, my whole life, I've never had a doctor ever check the pulses in my feet. And I mean, my doctor will occasionally sometimes now that I've been, diagnosed with PAD. But the only reason I was diagnosed was because I was having a CAT scan for stomach issues. So that's the only way that it came up. And I mean, I've had a vascular surgeon for the last 2 years, but I've never met him in person. It's phone calls only.
Wow.
Yeah, where are you in Canada, Kim?
Well, I'm in Vancouver.
Okay. And I was hearing, Dr. Coates, and I don't know how much you know about other provinces, but the care for PAD certainly varies from area to area to area.
Yeah,
And it
sounds like
seems,
it.
yeah, and it seems as though, my experience is that overall, the more advanced care, the people that are very progressive seem to be in Ontario, and especially those vascular doctors that are in Toronto. I mean, you don't just have one, you don't just have two, you don't just have three, but you have about half a dozen of some of the most advanced limb savers in the world that are there, in the Toronto area, doing the most advanced tools, using the most advanced tools and techniques to save limbs. So it's really interesting. And I don't know, is there a reason why you think that Ontario is so progressive? Is it because of those major universities?
I think it's because of the major universities. Yeah. Toronto's the biggest city in the country and has one of the top universities, University of Toronto.
Yeah.
Yeah, I find that patients get referred to the local vascular surgeons, but I've not tried referring anybody all the way to Toronto. I'm not sure how the catchment areas work. The next major center to us is London, Ontario, and often they send referrals back saying, see the local specialists. And there may be
Except they
some,
do.
fancier procedures they do in Toronto.
Yeah, there is the one with Dr. Giuseppe Papia, and they have an actual limb salvage program through Sunnybrook. So they take referrals from everywhere. So if you do ever have a patient that's on deck and they need advanced care, he and his partner are two of the best literally in the world. They try every single effort to try to save limbs. So they're good to know. Alan, go ahead and unmute and ask your question.
Hi, doctor. I've been I was diagnosed with PAD last February. I've been walking a lot and I feel like I'm able to walk further today than I could back in February. But I'm experiencing more pain in my feet, particularly in my toes. And if I rub the top of my foot right in the middle of it, it feels like I've scratched myself or burned myself, but there's nothing visible. I can't see anything. And my question is, I don't know who to go to. I don't know if I should phone my family doctor and talk with him about it, or should I talk with my vascular surgeon about it? I don't know what to do.
Or a podiatrist?
Or a podiatrist. I have seen a podiatrist in the past too.
So there's no
What do you-
wound present. You don't think your shoe's rubbing on it in that area, or
No, because when I walk, I don't feel it. I don't feel it with my shoes on. It's only if I put my hand on it, I'll feel it. And it feels like I'm rubbing over like a cut, or something that I've really scratched badly, but you can't see anything.
what's your sensation like distal to that area, like down at the toes? And do you have neuropathy further down? Because it sounds like it could be neuropathic, some sort of neuropathy.
I'm sorry, but I'm ignorant. I don't know what
I'm sorry.
neuropathy is.
Oh, neuropathy is where you lose the ability to feel, or you get like burning pins and needles type pain.
I feel some pins
In
and
your
needles
foot.
type pain. So that's neuropathy.
Mm-hmm. Did they ever do that monofilament testing? That little piece of plastic, and they
No,
ask which toe if you can feel where you're being touched.
no, I
No.
haven't had that.
Wow. How about a nerve study? There's a test where they can put larger needles in and pass electricity through it to see if your nerves
No,
work. No.
I haven't had that. But now I have not. I have a phone appointment with my vascular surgeon on October the 10th, and I haven't talked to him and told him that I'm feeling more pain in my feet than I was back in February when I was diagnosed. I haven't spoken to him since I was first diagnosed.
Hmm.
This will be my second conversation with him.
And the pain's not there at rest, and it's not there when you walk. It's just
No, it
when you
is.
touch it.
There is some pain at rest. And
Okay.
that's new. Like last February when I was diagnosed, I only felt pain when I walked.
Mm-hmm.
But now I'm feeling some pain in my feet at rest, especially
And
in
does
my
it wake
toes.
you up at night?
Not yet.
Well,
No.
that's a good sign.
Yeah, I'm still getting pretty good sleeps.
And no foot wound.
No, I have no wounds, no visible wounds.
So somebody with PAD, if they started having pain at rest, that would kind of raise a red flag for me. So you probably want to mention it to your vascular surgeon.
I'm going
As
to.
much as you
I'm going
can, that I
to.
used to get my pain only with walking, which is intermittent claudication, and then it
Yeah,
goes away with rest. But if the pain's
yeah,
happening all the time,
yeah,
that could be it progressing, getting worse.
yeah. I had a feeling
And
that's
that's despite your
what it is.
walking. Yeah.
Sorry?
Yeah, and that's despite your walking. And I think that
Yeah,
Dr. Coates, described that perfectly. And you have to make sure that you explain it to your vascular doctor as Dr. Coates just explained it to you, so
yeah,
that you can act, because um is the word trajectory. That's the direction that things can go. That's your
Yeah.
timeline. And that's a
And
very
that's
important timeline to share.
it could
okay,
be CLTI, chronic limb threatening ischemia, they call,
okay,
which is a worse form of PAD.
Yeah. And a lot of times, if you don't share that with them and they don't see a wound on your foot, they may brush it off. So you need to make sure to mention that timeline, because we do have a lot of people, and I know you're one of them, that you take really good care of your feet. And
yeah,
when you take really good care and you're very protective of your feet, that can sometimes work against you, in terms of getting the timely, effective limb saving care that you might need. So definitely very important. What area are you in again, Alan?
I'm in Kelowna, British Columbia,
Okay.
in the Okanagan Valley.
Oh,
I'm sorry,
fantastic.
doctor, I want to write that down. What did you call that?
Chronic limb threatening ischemia.
Okay.
CLTI.
CLTI, chronic limb-threatening hysteria,
Ischemia.
Ischemia.
is ischemia.
CLTI, which is when PAD progresses to rest pain. If it's getting worse,
Yeah,
you can have pain at rest.
okay.
And I see Candy has also joined us around here, and she's also in Canada as well. Hello, Candy. Let me know if you have a question for Dr. Coates, but in the meantime, I want to jump to Douglas has another question for Dr. Coates. Go ahead, Douglas. Douglas, go ahead and ask your question.
Yeah, I was curious. Where do you see this going from here? Do you see it advancing into the other parts of Canada? And how far do you think you can take this so that the primary doctors all over get the same experience that y'all are getting there?
I think this is going to depend on the success of our program. I think it's a little too early to tell right now if we're, preventing any amputations, but they're collecting this data. And hopefully, if it looks like it's saving the government money, I think they will keep promoting it or expand the program. I'm not sure what they're doing in other provinces. I'm sure there's similar projects in like Alberta or I would hope BC. I was going to mention.
How excited are you with this?
Pardon?
How exciting are you with this? Does it get you excited as a primary physician in getting the word out and helping other primary physicians get where you are today and where y'all are learning today?
I think it's exciting. Getting people screened who aren't getting screened, getting them the proper foot care education, and having a team to work with because family practitioners are so busy. It's nice to have, a wound care expert, our nurse practitioner. She has a whole team she can work with as well. She can refer to foot care nurse. She works with that's like your toenail care, things like that. She can refer people to get their offloading with their foot orthotics. We have smoking cessation program affiliated with the program downstairs, also mental health. So depression, anxiety is a major problem, and substance abuse issues can be associated with increased risk of PAD and limb loss. So there's actually an addiction program downstairs as part of our program. So she's got all these resources. I think it's great to have the nurse practitioner. Her name's Paulina, and now we have a lady coming on board named Harleen. Them there to help the family doctors in our community keep up with this. And so that's exciting to me. As the education, I also wanted to mention an organization up here called Wounds Canada. And I did a little promo speech for PAD Awareness Month for them, a little 1-minute blurb that they put on their website. But they have lots of information about PAD on their website, and they work with a group called the Limb Preservation Alliance, I believe it's called. Yeah, and they work with, I think, the American Podiatric Society, American Limb Preservation Society. I'm not sure if you're aware of that group.
Yep.
But there's a whole group of people that are sort of affiliated, taking on this problem. Wounds Canada does a lot of wound care courses and conferences. And so educating primary care, but some of the resources on their site is directed to patients.
Oh, good. And Ava has a question. Ava, go ahead and unmute and ask your question.
I hope I did it right. Can everybody hear me?
Yes, we can. Thank you for joining us.
Thank you, Kim. Thank you, Dr. Coates. My question was, I had heard you mention that people are more at risk with elevated cholesterol levels, diabetes, and things like that. For somebody like me who's had high triglycerides, high cholesterol my entire life, and now the doctor finally listened to me and did a lipoprotein, is that affect PAD as well? Because I know there's no treatment for it currently, but my doctor's not willing to do anything about it because even though my level is 163, which is super high risk.
Yeah, LP little a.
Yeah, LP little a. We finally gotten my triglycerides down to 193. My cholesterol levels are finally normal, but I know over the years, I've heard some of the doctors that I've seen mention that a lot of what I'm going through is genetic because my mom, my dad, my grandparents, everybody's had high triglycerides and high cholesterol. It's just that nobody's ever checked the LPA levels. And this is the first time, but even my cardiologist is like, well, we're not going to do anything about it. Just keep your LDL low at under 70.
I don't know about Dr. Cokes, but
Yeah.
I know that no other doctor has any answer for LP little a. There are a couple drugs that are being tested. I've actually seen quite a few of the Facebook ads where they were looking for patients for their studies on their drugs. And we do have a patient. Her name is Nancy. You might see her in the group quite a bit. And she just got enrolled in the study. So she's one to ask about participation in a study like that. I don't know if they've expanded it to Canada, but I know it's available in the United
Well, I'm in
States.
Florida.
Okay, so this is something that you could probably get involved in. And I'm sure if you used Dr. Google, you could find more information about these LP little a studies and see if it's possible for you to participate. And I can do an intro between you and Nancy, and maybe she can give you some more information on the trial she's involved with and see if they're still enrolling patients in that. We had addressed LP little a with our functional medicine practitioner, who's also a nurse practitioner that comes on every Wednesday. And she was saying that there are, some supplements and some foods that can actually help. But I think that they're overall foods that are just in general really good for your arteries, but that's worth checking into as well. But Dr. Coates, I didn't mean to steal the floor. If you know, any additional information on LP little a.
I think here it just kind of flags that you're definitely high risk and to be aggressive with lipid lowering, which still would be with statins up here. And then there's the newer drugs like PSK9 inhibitors. I'm not sure if you've heard that kind of med. And
I've
there's
heard
Repatha.
icosapent ethyl, which is kind of like your omega-3 stuff, but a
Like-
pharmaceutical version of it that help lower triglycerides. And if your triglycerides are still high despite the statin, despite Lipitor or Crestor.
I mean, I'm on Crestor and Zetia.
And Ezetrol or ezetimibe probably is our Canadian version. And I guess there's numbers they look at. If your triglycerides are still high, they would add icosapent ethyl, I believe.
I'm on that.
And then this other type of drug, PSK9s, I think, or if your LDL is still above target, despite maximal dose of statin.
And in Canada, so is the primary care that is doing most of the management for the medicines for PAD, or is that something that is managed? It's not managed necessarily by the vascular surgeons. It's either a cardiologist or family doctor, correct?
Yes. So I wouldn't refer somebody to a cardiologist with PAD unless they had CAD. But definitely a lot of them have both. So either internal medicine, if they didn't have CAD, if they had CAD, probably the cardiovascular specialist cardiologist would help deal with overall atherosclerosis, which basically the medicines are going to be pretty similar, right? And then endocrinology if they got diabetes. Sometimes I've referred to endocrinology about the PSK9 inhibitors and things like that. Not too many family doctors are used to prescribing those PSK9 inhibitors or the icosapent ethyl, although we should become more familiar with it and be incorporating this, but definitely it's nice to have a team with internal medicine, endocrinology, and cardiology to help out. And then there's the medications for, I guess, antithrombotics are recommended now, like Xarelto or rivaroxaban. Not sure if you're on that yet, or just aspirin. Or are you on aspirin? No.
No. Wow.
They put me on the ezetimibe, the Crestor, the rosuvastatin, the ezetimibe, the Zetia, and the Vascepa, which is what the fish oil you were saying. I had just messaged my doctor and asked him if there's anything else I could do, and all they said was keep your cholesterol or your LDL levels below 70.
Mhm.
So,
And
and
do you have
I did,
claudication, intermittent claudication?
I had an ABI study recently just done, and it was on the low end of normal, 1.34 and 1.32. My left leg is starting to get some intermittent claudication in it. My toes are a little bit colored. They don't seem worried about it. I am.
I think if you're symptomatic, they should be looking at antiplatelets and maybe, so like aspirin or Plavix, and maybe
Okay.
anticoagulant, right?
Yeah, Ava, are you in
Can't
Central Florida?
need-
Where are you at?
I'm in Jacksonville. The
Oh,
Jacksonville.
easy. Message me. I have a recommendation there for you.
I
Um,
will.
because you have a couple, you have one of the top interventional cardiologists there that that you might. So just message me and I'll share it with you. I
I
have one
will.
more question though. Sorry.
Yes.
Okay. And Kim has one more question for you.
Okay.
Yeah, I was just wondering, in your opinion, can cholesterol be too low? And the reason I ask that is like in British Columbia, your LDL levels should be 1.50 to I think 3.56, but mine's 0.68. And I'm on two different cholesterol meds. One was relatively new that started at the beginning of this year. So in your opinion, can it be too low, or could I cut back on a cholesterol med?
What are your triglycerides like? Do you know?
They're normal.
The upper limit's 1.7 usually in our units. Yeah.
Yeah, no,
Um, I
my
have
triglycerides come by fine.
generally found when I asked a specialist, they said there was no such thing as too low, I guess. So I have seen people with LDLs under 1 and they've kept them on it. Anyways, in our units, your target is under 2, definitely like 1.5, 1.4 would be awesome. 0.68 seems kind of low to me. Probably you'd have to ask a
Yeah, okay,
cardiologist or
thank
medicine doc
you. Yeah.
what they think. But my understanding is that that's safe to be at that level. And certainly I would think it would have some increased benefits for you not continuing to build up atherosclerotic plaques in your arteries.
Okay, thank you.
And Kim, you had one more question I think I saw in there. About exercise?
Oh, no, I just wondering, in your program in Ontario, do you have an exercise program associated with the rest of what you're doing?
Okay, so in Ontario, we have cardiac rehab, which is for heart patients. There is with coronary artery disease. There's chronic disease management programs, which have exercise programs not directly geared to PAD. And there's respiratory rehab, hard to get into. But our program, we have a kinesiologist as part of the team downstairs. And so I'm not sure if Paulina, our nurse practitioner, is referred to him, but I think he certainly could devise exercise programs. But there's not a supervised exercise program per se where they go in and walk on a treadmill and have a kinesiologist checking their blood pressures and things like that. But yeah, definitely that's the other aspect to treat this as the walking. And so hopefully we can
Cool.
get something more developed.
Yeah, that would be amazing. And maybe we can help you through the Global PAD Association because we have an app actually that you can use and it can be monitored by your team. But we actually have the program that's available at no cost to facilities to be able to send to patients. And it's also at no cost to them as well. I want to respect your time. I do just have a final couple of questions here that we ask every single doctor. Every doctor. And they belong to a couple different series. The first series is what we call the 6 minutes that matter. So that, defining moment in your career. Was it a conversation you had? Was it an event that happened? Was it something you saw, something you read. What was that defining moment in your career?
That led me to
To
take on the
something.
cause, saving
It
limbs.
could be taking on the cause. It could be anything. We've had, people talk about, for example, one doctor said that the defining moment in his career was a conversation he had with his mentor, who said to him, if the contrast fluid can get through, you can get through. You can get through any blockage, even if there's just a trickle of that contrast fluid. If it can find a way, so can you. We had another doctor and so that's how he now treats people. He now doesn't give up on patients as soon. He's like, okay, well, if that contrast fluid got through, I can get through as well. And we had another doctor that said that he decided to go into angiography. He went from being a cardiologist and going into general angiography and taking on PAD. When his wife said, "You don't seem very happy. What's really going on with you? What more would you want to do?" And that was really the defining moment for him to stop and think, gosh, what would I be wanting to do if I could do anything and I had my family's support and I had the time? What would I want to do? And that's when he went into angiography and ultimately became one of the top limb saving specialists in all of Germany. So, you could even share, the moment with your sister. That could be the 6 minutes that matter. This is a whole different segment that we air separately. And so if you'd like to share, if you're ready to share your defining moment.
Yes. So I would say that probably my experience with my sister would be the defining moment as far as my drive to help save limbs and screen and treat PAD. I didn't really realize how severe this problem was until I experienced it personally, to see how traumatic it was for my sister and her loss of independence, her fears about how she was going to make a living after losing her leg. And it's crazy. In Canada, we have a hero, Terry Fox, who lost his leg to cancer, and he ran across Canada, halfway across, doing a fundraiser back in 1980 till his cancer came back and he had to stop his run. But you sort of think, oh, you'll get an amputation and just get fitted for a prosthetic limb and you'll be able to run across Canada. We have this strange idea that it's an easy thing to go through. But then I realized that the rehab and getting fitted for a prosthetic is a huge ordeal. The stump, residual limb, changes size. You have to be recasted, and then you're not in the physio clinic again while you're waiting to get your new limb made and fitted. And they're super expensive. So the best limbs, good ones, cost like 60 to 100 grand Canadian dollars. These are the Autobach and Osser Rio sort of limbs. It was just astounding, like what this costs. And if you're losing it from diabetes or PAD, often you don't have coverage to cover the better equipment, right? If you lose your limb in a car accident or in a war, you generally have some sort of travel insurance or car insurance to cover these sort of things. But yeah, that just blew me away, and I felt so bad for my sister and what happened to her. So that really was the impetus for my wanting to be involved. And I really have to thank the team up here at Windsor Family Health Team where I work, who invited me to help. And so that's my executive director, Margot Riley, and Ron Shepard runs the Team Care Center downstairs where the lower limb program is housed. And they both asked if I wanted to help out, recognizing what happened to my sister. And they were really kind. They said, you can help as much as you want or as little as you want. We know this could be traumatic for you, thinking about your sister and what she went through. And so, I have to acknowledge, if I win this award, I definitely share it with them and with the nurse practitioner downstairs. If it weren't for them, I possibly wouldn't be this involved. And it has been a great experience.
And through your experience there, we have a series called Journey to Diagnosis. And it's an encounter with a patient that you just have to shake your head and go, oh my gosh, how in the world how was this missed? how is PAD missed? You've got to be kidding me. And
Hmm.
how you were able to facilitate care for this person.
Hmm.
Do you have I know when I ask this of doctors, they go into a long dissertation about, well, you want just one? Really?
Mhm.
Isn't this like every patient that comes my way? How
Mhm.
has anyone else missed this? I just don't get it. How is it that you had a spinal fusion that didn't relieve any symptoms and they never bothered to check
Mhm.
for PAD? How is it possible that you ended up, with compression stockings when it was actually an arterial problem?
Right. Huh. I can't remember any case after what my sister went through. It's kind of like blocks out everybody else.
I know, and I think that is almost, really the case. Like, how is
So,
it that it was missed on your sister? How did they miss this?
mhm. I think it was poor exam, like poor history taking and poor hands-on physical exam. I'm not sure if she fell through the cracks because of the pandemic. I know that she saw the doctor in person. They were in the same room, but I don't. He did not check her pulses. So
Until it
yeah,
got to the
I
point
think.
of critical acute limb ischemia.
Mhm. I think patient education is really important, and just partly why I'm glad about this program that we're trying to identify patients at risk and getting them assessed. And if you're too busy in your primary care practice, at least people can refer to our program.
Mhm.
Um, because a lot of people would come in embarrassed about a foot wound and have left it too long.
Yeah.
I recall this in my practice where patients came in and, you took their sock off and they probably felt bad because I like grimaced horribly at the smell of the gangrene. And,
Um,
they just didn't realize how severe it was. I had somebody else who had a heel wound and I hadn't seen her for some time because of the pandemic, but she went to a local emergency department, got referred to a general surgeon, and it seemed like things weren't referred very well from this peripheral smaller hospital and the general surgeon. I ended up referring her to the Lynn Wound Care, so at least that was set up. But I never directly saw this wound. And this was a sad story. She ended up falling at home. I'm not sure what her offloading equipment was for this heel wound, but she died shortly after having lain on her apartment floor for like a day till somebody came and found her. But again, with this offloading, you got to look at their whole social situation. Who's there to help somebody? If they live alone, can they get some home care? Can they live with another family member? Because they're high risk for other injuries when they're trying not to weight bear on these wounds. Um, I don't know
that's
if that
so
answered your
sad.
question really, but
Yeah,
sorry.
that's really sad. Oh my goodness. Thank you for sharing. And, just even people hearing that story, hopefully it'll help prevent that from happening to other people. And do you have time for just one more question? I think Marsha wants to ask you one more question.
Sure.
Marsha, go ahead and
Thank you,
unmute.
Kim. Thank you. I'm just curious, since this happened to you or your sister, a family member, like the doctor who never touched her foot or, who really didn't diagnose it. And I understand he was an American doctor, so different countries, but like, did you have conversations with him or like how does he go forward, hopefully with more knowledge and to go on and help more patients? But the fact that somebody basically died from possibly his negligence, I'm just wondering what the fallout of
Hmm.
that was.
Or even ignorance.
So,
Well, it could be
I
ignorance.
felt, I felt horrible that I didn't catch this, but the border was closed and she was in Vegas during the pandemic, and I'm like, get it checked out. So she goes and like, oh yeah, they checked me out. I got a venous Doppler. And we were all like thinking, okay, everything's okay. And then, a month or two later, she's like, my leg's killing me. I got to go to emerge. And, there was a lot of guilt that I felt. she sent me a picture of her leg, but she had her shoes on. And now I know socks off is like my favorite saying now. When patients come in, can you take your shoes and socks off?
Yeah.
Because I'm not
Did
sure
you
that
ever
that
have
doctor did that for her, and I wish I had, asked her more questions, but I guess I just trusted the system. And the doctor at that clinic, so after my sister died, she died 7 months after her amputation. Um, there was a question of, whether to look into litigation and stuff, but since we were across the border and the border was still closed, we just kind of didn't really pursue it, and we didn't, I don't know how it would work. We didn't have a living, person to fight their case when they lost their leg. So, maybe it's possible, but
our family had a similar situation and never pursued it legal. Hopefully that, doctors are human, and hopefully he learned the greatest lesson, unfortunately, at your sister's expense, but let's pray that's the case.
I haven't phoned him or sent him a letter, but
You
maybe
did?
something to think of. Say, do you remember this note? Seeing this lady, here's your copy of your note. And 2 months later, she had her leg amputated. And I
It
noticed she
would be
didn't check her
interesting.
pulse or anything.
I know. I wish we could
It would
figure
be
out who that
helpful.
urgent care doctor was and give them a little education. I ended up doing that with my mom. I lost my mom 2 years ago, and I have the same, if you ever want to talk about, I have the same guilt. I'm in the business, I'm in vascular. How is it possible that I even missed this? Why didn't I get on the phone with my colleagues and say to the doctors, hey, review my mom's case, review her symptoms, let me just spill out all these symptoms, and if I might have done that, she might be around. But
Mhm.
I was able to, I was ready to go after one of the doctors for negligence, and it was interesting, he ended up calling me, and not knowing that I was thinking this, but he had just heard what had happened, and he called and he apologized personally, and he said, I know I'm opening myself up,
Mhm.
for things, and I shouldn't be saying this, my hospital would advise not, but I have to tell you how sorry I am. I can't believe I didn't touch the patient. I can't
Mhm.
believe I missed this. And I'm so sorry. He said, from the bottom of my heart, I know it doesn't bring back your mom, but I wish there was something I could do. And I said, well, now that you're calling, I said, what you can do is make sure it doesn't happen to anyone else. And he said,
Yeah.
oh, I will. He said, I can't believe that I missed this, and it
Mhm.
won't happen again. And so, right, it's, um, so I hope maybe you can reach out, to this person and see if you can
Mhm.
find him, if he's still practicing. You have questions that just keep coming in. Are you in a hurry?
Me? No.
Okay. Then you're a very popular, this has not happened before. We're ready to close. I say, here are my final two questions. And then everyone wants to ask you more questions. So you are very fascinating. And your empathy is just, it's so contagious, and your passion is contagious. So I think that's why. We'll get Alan, and then Douglas wants to pop back in. Go ahead, Alan.
Doctor, do you know why the mortality rate of people that get major amputations is so high? What causes that?
I know they're at higher risk for heart attacks, events such as that, and maybe osteomyelitis, bone infections, sepsis.
Okay.
Immobility.
Yeah. I think everything gets
Immobility,
worse
yeah.
when you're not moving.
Yes,
Yep.
yes, yeah.
Yeah.
He is to keep moving, keep moving. And that's why I tell, if any of our patients, and, I always look at amputation as being a failure. But in some cases, such as like in your sister's, that was an acute situation. And sometimes in those acute situations, the leg has got to go, and that it's treatment, but yet it's still a failure of the system. Right. But I tell all the ones that have had amputations, I don't care how you move, you got to move, you got to move, you got to move. We got to find a way you
Yeah.
can exercise. We've got to find a way that you can improve your circulation. while you're sitting there, while you're waiting for your prosthetic. And so, and even with your prosthetic, we got to get you in a cardio rehab program to keep you moving.
Right.
Douglas,
saw-
go ahead and ask your question.
But Alan kind of stole my question, but I had a thought. Like I had an axial bifemoral done, and I saw a lawyer because I was told by quite a few doctors it was put in the wrong place. And when I saw this lawyer here in the state, I'm in Texas, here in the state of Texas, they passed a law here a while back where there's only a certain amount of judgment you can get anyway from a doctor, and it actually doesn't go through the doctor, it goes through his insurance. So the doctor never really had to show up in court or anything. The insurance people would. So it kind of makes you think the doctor doesn't have to worry about that kind of stuff now, where they can, does it make them free from having to take that on, that responsibility of doing things the right way and being responsible in their care, in a patient's care? I hope I'm making sense there. So
There's a difference between, and this is where I think the line of delineation is. There's a difference between ignorance and negligence, and ignorance is not necessarily it's not seen in this industry just because you may not know. How do you know sometimes what you don't know, right? And you want to encourage doctors to practice medicine. There are a lot of things that can be used off label. For example, there was a drug that if it, it was used for my mom at one point for her Crohn's disease. It was used off label for Crohn's disease for her because the doctor saw that it in other patients for its other use, that it was helping some of his patients who also had Crohn's. So he had put that on for my mom. Now, if there was, wasn't some sort of protection for him, he probably wouldn't have done that. And my mom wouldn't have gone into remission with her Crohn's, which a lot of other Crohn's disease patients at that time didn't have that opportunity to go into remission. And it led to I think their colons being removed and they had to live with a bag and things like that. And we see it also, Douglas, if you remember, we did the interview with Dr. Raman Varco, vascular surgeon from Sydney, Australia, who was telling us that he uses a coronary stent in the tibial vessels, in those below the knee vessels. And he said it's literally improved the patency rate and the limb salvage rate, the durability of those procedures, because he's able to use the coronary stent and has figured out that if he uses it off label, it's not indicated for below the knee use. But he felt it was safe, and it turns out it was really effective for below the knees. And he wouldn't have done that if there was.
I think the point, though,
for
Kim, for me was I would like to ask the doctor, and Dr. Coates, this would be a good question. If a client came to you and said, when was the last time you've been to a conference? When's the last time you studied something new or you learned something new? But I was a licensed chemical dependency counselor. Every year we had to have a certain amount of credits to keep our license. So, yep. I mean, I would like to go back to that doctor and say, when was the last time you learned this technique or that technique? Or did you just stick to what you knew?
Right. I mean, in Canada, and we have to have a certain number of credits of education per year. I think it's 50 hours a year. And that gets submitted to
our, of your clinic schedule.
To our College of Family Physicians. Yeah. So 50 hours of conferences, basically, or courses.
Yep.
And
it's the same in the US, and all over the world. I mean, every doctor, every physician, and clinician, they all have to have some sort of continuing, call it CME credits, continuing medical education credits. Now, I don't know about there, but I know here that doctors have the freedom to attend whichever ones they want. They have to be meet the CME standard, right, for those credits. But you can choose what you want. So if you want to choose to go in one direction on, let's say you love the idea of, for a vascular doctor, aorta. So all you go after are the educational series on aortas, but you still treat PAD patients, and you're not going to the educational seminars to learn the new tools and techniques, and you just continue to treat still PAD patients and the way you've always done, not knowing there's something new. That's where I kind of see, the problem. And I see that happening, a lot, with some of the vascular doctors is they only go to the seminars they want to go to, but they don't necessarily go to the seminars they need to go to.
Right. So I don't know how they figured that, how they figured that out. But as far as if somebody did a procedure that was inappropriate or old-fashioned, I guess, and you wanted to sue them, I guess what are they for negligence? Did they make a reasonable medical decision or treatment that somebody else in their field would have done, right? Based on current standards of care?
It
In
would
which
have to
case you'd
be,
have
and
to
that's
ask your lawyer to ask, if they have a vascular surgeon who would comment on whether the procedure was adequate for, 2024.
Yeah. And I think that's always important. The standards of care are pretty broad, but they're also fairly clear. And so, yeah, as long as it meets standards of care, it's just like, amputation. Well, that's kind of a blurred line there, because there might have been an option available, but if that doctor doesn't have that option in his armamentarium, then it's not necessarily considered negligence. That doctor did what he or she needed to do in that moment, and amputation is part of a standard of care. Ultimately, I think that is going to change in the future. They're looking at here in the US, legislation that they're hoping to pass to require a vascular evaluation prior to amputations. I don't know where that's at this point, but it is something that has to come down from the higher ups before it can be something that could be litigated. But thank you so much. Wow, that's kind of a fun place to end end this conversation. I wanted to introduce you. We also have Candy, who's also there from Canada, and she's played an integral role in trying to promote education on PAD in Canada. I don't know if she wants to unmute for a second and pop in and say hello. Let's see.
Hi. I'm sorry.
Candy. Welcome.
I'm beginning of the meeting because I was at my ophthalmologist, who's an hour and a half away. Yeah, between my eye and my foot, there's not much left in the middle anymore. So I'm not, and I don't have pictures up, so I don't know who's talking. I'm kind of guessing. I see there are a lot of people there from the States.
Mm-hmm. We've had quite a few from Canada as well, but we have Dr. John Robert Coates here from the physician in Canada.
I did see his picture briefly before. I was pushing buttons here, trying to figure out what I was doing. No clue. Kim, that I have no knowledge of technology.
That's okay, but we are live streaming right now online. So I don't know if you had a question for a family physician about PAD or about the promotion of PAD for Dr. Coates before we ended this seminar.
A question about it. I'll tell you, Kim, I have given up. I've been treated really badly here, I think. And as far as I'm concerned, when I can't deal with my foot anymore, I'm gone. And that's where I'm at.
Isn't that's so frustrating to hear? Where are you at in Canada again?
Cape Breton, which is the northern half of Nova Scotia.
Yeah.
So
that's really frustrating to hear, isn't it, Dr. Coates?
Yeah.
Different people have
a vascular surgeon in Halifax, or did they have them?
Yes, Halifax, 4 hours away from me.
Wow.
I've dealt with 2 vascular surgeons. This has been going on for years or so, actually maybe more than 4 years. I've dealt with 2 vascular surgeons, one who was a very lovely, lovely man who did absolutely nothing. The other one who was a very aggressive, almost to the point of nasty, doctor who either it's bypass or nothing, don't bother me, basically. So, and I refuse to have the bypass done. I just flat out refuse it. So I'm just living with it. And and that's the way it is.
Wow.
Tough to hear. I'm so sorry you're going through that, Candy. And we can also take this offline, and we can still try and work our way through this. As you know, bypass is part of the standard of care. They can last for a number of years, but it also depends on whether you are a surgical candidate for many other reasons, and whether or not it might be right for you. So we also, as we have Kim who's in chat, and she says that Dr. Giuseppe Papia says that he sees people from other provinces. And so if we can figure out a way maybe to financially get you there, that might be an option for you as well. So hopefully we can work on this and give you a little bit of hope.
Yeah, well, it'll be a tough one, as I did everything I could think of to do, and well, there's a whole story here, but
Yeah.
Did they have a out of province approval process for procedures out of province? We have it in Ontario, so maybe somebody would help you complete an application for that and get you to Montreal or Toronto.
There's a patient in somewhere in Nova Scotia has been on the news. She has lymphedema, and she's a fairly young woman with 2 young children, and they will not pay for her to go to another province to get the treatment that's available, and it's a lot. Because there is no specialist here because there is no specialist in Nova Scotia that can say she needs it. And it's been on the news. Like, it's that pathetic. And they say, oh, we're really trying. No, you're not trying. If you're trying, you do it. But they're not. So yeah, it's I'm an RN. I worked in hospital medicine and surgery for 35 years. So whether it's because of that or in spite of that, I don't have a whole lot of faith to begin with. And nothing that's happened here is the only thing I can say is good is I went to a GP that I'd only ever met once, who kind of gave me the creeps. I walked in there, I said I got pain in my calf, and he sent me immediately for vascular studies. And he's the best one that's done anything. So there you go, GP.
Well, thank you, Candy, for your courage, and thank you so much for sharing. And we're going to do what we can to help you out and see if we can get you yet another doctor and help you get a referral to get another opinion over in that region. So I know that new doctors across Canada are learning the newer tools and techniques every single day. And so we just have to keep checking back and seeing if there's another and another and another. And we're going to keep working with you. We don't give up on you, my friend.
Okay.
Thank you, Candy. And thank you so much, Dr. John Robert Coates. We really appreciate you. Congratulations again to you, as well as I will give a shout out to your entire team. You are the PAD Gatekeeper of the Year award winner through the Global PAD Impact Awards, brought to you by the Global PAD Association. Congratulations, and thank you so much again for all you do to continue to save life and limb. And through this, I want to honor your sister and just raise her up, along with this.
Thanks so much.
Thanks, Dr. Coates.
Honored.
And doctor, you're making a difference. Don't forget that. You kind of are the needle of making a difference in Canada and changing things. So I think your sister is very proud of you and what you're doing, and you are making a difference.